Hyponatremia is one of the common endocrine emergencies which is encountered in pediatric practice, and this is one of those conditions which is quite important in terms of the overall clinical perspective and in terms of challenges in terms of diagnosis and management. So the key principles of management are that do not give emergent treatment unless it's an acute severe form. Very importantly, be careful about rate of correction. In severe cases, you can go up to 12 because there the osmoles have not been extruded. In moderate cases, 6 to 9. Chronic cases, less than 6. Very importantly, underlying condition also needs to be treated. So if you have SIADH and fluid overload, do a fluid restriction. Hypovolemia, you will give normal saline in that regard. So this is something which you have to be very, very careful. If you are able to correct it orally, give it orally. Usually if you are giving IV, the typical sodium is around 70 to 100 and 120% is what is required in that regards. So the acute treatment will depend upon the duration and the symptoms. Now, often you may not know the duration. So we have put that also as a caveat. If the duration is less than 48 hours, child was fine 48 hours ago and suddenly there's a problem and the symptoms are severe, sodium is less than 120, coma, seizures, this is an emergency. You have to do everything to salvage the child. So you give 3 to 5 ml per kg of 3% saline and rise by 9 to 12 millimoles per liter per day. If you have mild to moderate symptoms, sodium 120 to 130, headache, confusion, you will give small push 1 to 2 ml per kg of 3% saline, rise of 8 to 9 millimoles per liter per day. If your duration is more than 48 hours or it is unknown, then you assume it to be chronic in that regards. Still, if you have severe symptoms like severe hyponatremia, coma and seizures, you will correct it using 3% saline, but rise will be lower, 6 to 8 millimoles per liter per day. If it's mild to moderate, you have nausea and other features, don't give 3% saline, you correct, rise it by 6 to 8 millimoles per liter per day. So very importantly, acute severe, acute moderate, give some 3% saline, but rise has to be slow. Chronic, the rise has to be absolutely low in that regards. Now, often we have to answer about how do you manage hyponatremic dehydration. There are various ways to do that. We have put forward a simplified way. You look at how much is the fluid deficit based upon dehydration level, which will basically be 0.6 into weight minus deficit will be your estimated body water. Then you calculate the hyponatremic sodium deficit, which is estimated body water into 135 minus sodium. Isotonic sodium deficit, which is fluid deficit, into 140. Then you will know the maintenance, of course, which is 4 to 1 or 150-20 formula, sodium of 2 to 4 millimoles per kg. Then you correct and deduct the bolus fluid volume and bolus fluid porphyria, and you get the final fluid in terms of volume and tonicity. So very importantly, you calculate the fluid deficit, the sodium deficit, which is hyponatremic and isotonic, and then you correct it over to avoid a rapid correction in that regards. Whatever calculation you do, you need to have close monitoring, reduce rate if there is a rapid rise, relower if there is a symptomatic scenario in that regards. A word about SIADH. Now, the problem here is that your fluid should be restricted, 60% of maintenance, 1 to 2 millimoles per liter per day. If you give sodium chloride, you will actually lose the water in that regards because ANP is high, aldosterone is low. So sodium chloride is not going to be a solution. If you want to give something, give 3% saline, which is actually a osmolar diuresis. So that's why we use plain NS. 0.9% is not going to make any benefit in that scenario. What about vaptins, which are V2 receptor antagonists like tolvaptan, conivaptan? They are not recommended in acute hyponatremia in children. You will have a rapid rise and there will be a lot of problems which will be happening. So don't use vaptins in the acute state. You can think of in chronic state in that perspective, and that's important. In certain situations, you can induce a DI-like picture using lithium or demiclocycline or urea in that scenario. So we have a 13-year-old girl with drowsiness and hyponatremia. Urinary osmolality is on the higher side. SIADH was diagnosed and tolvaptan was given. Now, this is important. As I said, don't use these agents because they will cause rapid increase, and this will cause what is known as osmotic disequilibrium syndrome. the manifestations of which will be later. You won't have an acute manifestation. This is a very, very problematic scenario. 16 hours later, abnormal speech and vacant stare. So this is a rapid rise. So osmotic disequilibrium syndrome is a very dangerous situation, typically happens with severe hyponatremia, rapid correction, and there would be a time phase. It is not an acute phenomena. You will see it after 24, 48 hours. It's all because of the osmoles, and you cause rapid correction. Your balloon goes up and then it comes down. It will shrink and it will get damaged. That's what is very important from that regard. So if you have anybody who has a chronic hyponatremia, fluid changes, look at the eyes for the pupils, whether they are constricted, look at speech defect, look at other parameters, because that's something which is very important in that regard. So what do? We can think of a salvage therapy. So this is what you want, the sodium to gradually rise. But if you have given baptin, as in this case, sudden rise, what you need to do is to do a relowering. So you can do here either give a desmopressin, vasopressin, or free water to decrease it. So if you track it properly and you know that the rise is more than 9 to 12 in acute severe, 6 to 9 in acute moderate, you give more free water to bring it down. This is very, very important. Otherwise, the patient will go into osmotic disequilibrium syndrome in that regard. So 9-year-old girl with CLD, sodium is 115, anasarca, drowsiness. Now here 3% saline was given. This is not really recommended because this drowsiness could be because of hepatic encephalopathy. She may have chronic hyponatremia. So no point of doing that, and you will have severe problems in that regard. So if your duration is above 48 hours, generally do not give 3% saline. That's the big message in that perspective. What about this girl? 18-year-old girl be diagnosed with AIP, has headache. This is acute hyponatremia. There is headache. So in this scenario, we can not give, we don't need to give 3% saline, but we can give correction and fluid restriction, which is there. But if you have severe abnormalities, seizures, and anisocoria, like this person with head injury, you have severe hyponatremia, high urinary sodium. So this is more like a cerebral salt wasting. Here, there is severe symptom. You give 3% saline and seizures will be controlled. So give 3% saline if you have an acute severe or an acute moderate effect. What about specific management? Think of if there's a fluid overload, correct the cause and do fluid restriction. SIADH, fluid restriction in V2 receptor antagonist, not in the acute phase. Adrenal insufficiency, give hydrocortisone and fludrocortisone. And in PHA, give sodium chloride and furosemide in that perspective. In Bartter syndrome, you can use indomethacin. Dr. Linda is talking about what is about a case of very low sodium and normal potassium. This is an unusual scenario, and generally speaking, I have seen a couple of cases with severe MPHD who can present like that. Sometimes you can have severe SIADH because of a nephrogenic SIADH, which can cause, but this is an unusual scenario. If you talk about sodium levels less than 110 or 120, that will be unusual. Usually 120 is okay. Less than 115, that becomes difficult. Dr. Rajiv Das is asking what would be the initial food in a 6-year-old child with body weight 20 kg admitted involved with Japanese encephalitis so that hyponatremia can be prevented. So generally, more people are more talking about in terms of more fluids, which is appropriate, more physiological rather than the hypoosmolar foods. So Dr. Pratik, what will be your take on somebody who has a JE?
So initially, we are at a risk of developing hyponatremia. So more than the fluid, it is the regular monitoring of the fluid which we should do. Because normal saline, we can see whether how the sodium is dropping or rising more than exact fluid we are giving.
Generally, we should look at the maintenance fluid, whatever is recommended for anybody else. There is no routine recommendation to restrict fluids in that setting or to really look at different fluids. You monitor the sodium. That is more important because it may not develop in many cases. You will have normal, and then giving less fluid may be a problematic scenario. Dr. Rajiv is also asking about volume status in kwashiorkor. That's again an interesting scenario. So then uric acid may be a role in that perspective that will give you a picture in that regards. It will behave more like a fluid third space loss scenario. So more like a CCF or a liver disease or nephrotic syndrome. Dr. Ashubu is asking when looking at rate of fall, what should be the interval between the requests? So generally speaking, that will depend upon the severity. I would say 3 to 4 hourly will be reasonable in that regards. If you're giving an infusion, then you have to be more careful, but 3 to 4 hourly is good enough. Dr. Subhash is asking low sodium, low potassium. The most common cause I would say would be diuretic use. That's what we encounter less in children, more in adults, but that's the most important cause. Rarely diarrhea with inappropriate ORS will be the second scenario. The third would of course be tubulopathies, but diuretic use number one would be that in that scenario.